All right. Welcome, everyone, to our May Sunday conversation presented by the Massachusetts MECFS and FM Association, otherwise known as Mass ME. I'd like to extend a special welcome to our Mass ME members today. Your membership makes it possible for the organization to host and sustain the Sunday conversations, support groups, patient services, and more. If you'd like to learn more about how membership helps the organization or to become a member, please visit our website at massmecfs.org/join. Now I'll introduce the speaker for today. We're joined by Dr. Ruth Axelrod. She was born and raised overseas, a child of American expatriates, and there she attended an international school in the Himalayan mountains and college in the US. She has a career in health services administration. She served as operations manager, working closely with doctors and clinical care professionals and patients for an NIH-funded General Clinical Research Center at the Methodist Hospital in Houston, Texas. She also served as a senior manager and internal consultant for the Medical Faculty Associates, a 365 physician multi-specialty group practice at the George Washington University in Washington, D.C. Her managerial work there fostered Ruth's fascination with human behavior, leading to a career transition to become an academic professor and consultant in individual and group behavior in organizations. There, she specialized in leadership, team building, conflict management, and the psychology of decision making. Ruth earned a Master's of Health Services Administration and a PhD in Management from the George Washington University. And upon her retirement, she also served as a management consultant for various nonprofit organizations. So, Ruth, we welcome you and thank you so much for presenting with us today. Take it away.
Thank you, Helen. I am absolutely delighted to be here. I haven't given a professional talk in several years, and you'll understand why when I tell you a little about my history with my chronic disease, the main one of which is chronic fatigue syndrome, fibromyalgia. The purpose of my presentation is to help empower you in your relationships with doctors and other healthcare practitioners. In other words, to help you take charge of getting the healthcare that you need and making sure that people are as responsive as possible to your individual requirements. Um, I would like to point out that not everybody here in the audience is on the same page with regard to knowing how to use the healthcare system. So please be patient with me if you feel that I'm teaching my grandmother to suck eggs and that you know what I'm talking about. But remember that there are other people who may not, and that's why I'm trying to cover all the basics. I'll start with my own story. For all of my early adult life, I was involved in the field of medicine, beginning with going to medical school, quote unquote, with my college boyfriend, who was later my first husband, and immersing myself in friendships that were more often than not with clinicians and biomedical researchers. For 20 years, I worked as a senior administrator, an operations manager in various healthcare settings. As Helen said, those included a clinical research center and a 365 physician group practice with 16 different specialties. In my early 40s, I became increasingly fascinated by questions of human behavior and change in organizations. And so I switched fields to work on a doctoral degree in management so that I could do research and teach at the university level. To earn my living, I took up teaching at that time. In February 2004, I came down with the flu. It was exactly 2 weeks before my dissertation defense, which is that last step in a PhD program where you present your research for the critique and approval or not of a faculty committee. I'd been working intensively for months, analyzing my data and writing up my research, as well as attending to my students' needs. My dissertation defense was very well received, but the flu did not die back. In fact, as time went on, my symptoms expanded and became worse. My PCP, at that time a wonderful internist, ordered new rounds of tests, each more exotic than the last. I recall one terrible morning when I stepped into the bathroom for a shower. There was no soap. It was in a closet about 15 steps down the hall. It seemed much too far to walk. I flopped back down on my bed and cried myself back to sleep again. 6 months later, my PCP said very gently, "You have chronic fatigue syndrome and fibromyalgia. There are no established treatments for them, and both of them are very difficult to work toward a resolution for the patient." The reaction of the people around me was very sympathetic and supportive, and I consider myself very lucky in that. A colleague's husband, a highly trained Chinese medical practitioner, said, "Too much yang, too little yin." From the perspective of the human body as an energy system, I had overused my active and expansive capabilities and engaged too little in the passive and reactive. He advised me to eat more roots to become grounded. My department chair, an organizational psychologist, said, "Now maybe you'll slow down to the speed of the rest of us." And she rearranged my class schedule so that I could manage it. Another colleague, a behavioral therapist, said, "Wear sexy underwear and save your energy by paying someone else to clean your home." My husband gradually took over most of the household tasks that we had previously shared so that I would have enough energy to continue working. I knew I would go crazy if I couldn't work. As my fibro fog increased, I faced the devastating death of my dreams. All my life before that, I had prepared to be a scholar in the field of human behavior. In both undergraduate and graduate school, before I became sick, many faculty had told me that I could be a great theorist. One even offered to find me money for graduate school if I would go into his field, which was bioethics. Now I began to realize that that was not going to happen. As I said, it was devastating. Forced me to change my entire self-image. Although I could no longer read and comprehend scientific papers, I realized that I could still teach very competently. And so I did. As Helen said, I taught leadership, individual behavior, group dynamics, conflict management, and the psychology of decision-making, and various other topics, including trust, which had been the subject of my dissertation, interpersonal trust. How to develop it, how to keep it, how to recoup it when you lose it. I taught mostly graduate school, in person and online, for over a decade. I retired at the age of 64, which was much earlier than I had expected. I had expected to work until I was 70 or 75. But I quit the struggle of intellectual activity and turned to volunteer work to help keep me engaged with life. For the next 6 years, I worked with small nonprofit organizations to help them develop and find funding. I also began creating gardens for a village library and homeless shelters, as gardening has been one of my lifelong passions. So one thing that I did was revisit everything I loved doing and pick and choose things that I still could do. In 2022, 4 years ago, the growing intensity of my widespread body pain curtailed even those activities. And I deteriorated into being largely homebound. Minimal physical activity reduced my capabilities still further. No matter how hard it is, you have to keep active in order to be able to be active. And I spiraled downward until a few months ago when a pain specialist introduced me to the drug that is, again, changing my life. I still require 11 to 14 hours of sleep a night and a full day's recovery after any excursion, even just going out to dinner. But I have renewed interest in living an active life. And I now have a new goal. I want to be able to get back to walking 5 miles again. Ben, my advancing controller is not working, so would you please advance the slide?
It's on the next slide.
Thank you. Working with medical practitioners. As I used to teach my leadership students, developing relationships is a process that best begins with an examination of what is going on inside of us, our assumptions, our biases, and our expectations. Knowing these things about ourselves positions us to most fairly and accurately recognize who the other person is and how he or she engages with the world, in specific with us. He or she may have a very different way of engaging in the world, but once we recognize this, we can adjust to it. I don't know if any of you have taken the Myers-Briggs test, but that's one that's used to help people understand the difference between themselves and others. We can then select effective approaches for working with each individual. Finally, after each encounter, it is helpful to analyze what happened and make course corrections. The US military calls this process developing an after-action report. And it's the process of developing that after-action report that is the most useful. It can often be best done with a friend to serve as a sounding board. Next. What do I hope for? That's starting internally. As I internalized the fact that I was now had a disease which might be incurable, I worked consciously and conscientiously to evolve my lifestyle and my sense of self to match my new capabilities. I expect that process to continue for the rest of my life. It involved leaving behind much of who I had been and gradually, painfully developing a new way of being in the world. Remember, more yin and less yang. In my private life, I had to drop most of my creative hobbies to fit my new energy level, but continued reading, some writing, gardening, and landscape photography. And I recalled that I had been through this kind of thing before, because when I was a young adult, I used to make all my own bread. And at one point, I quit that to go on to other things. We can survive giving up some of the things in our life, as long as we keep our eye on our passions and our bliss. For the first 10 years, I used all my research skills to search for a doctor who thoroughly understood my diseases. I searched online in the clinical and research literature, looking for doctors who were part of panels that defined the disease, developed diagnostic criteria, and suggested treatments. I found some, but most of them were researchers. They were not clinicians. I got in touch with MassME, and the fabulous volunteer staff there provided me with a list of specialists whom its members had found to be helpful, and I called up some of those. Unfortunately, but hardly surprisingly, most of them had full rosters of patients and couldn't take on anybody new. Conventional wisdom for a 72-year-old like me, with over a dozen chronic diseases and 8 prescription medications itemized in my PCP's 3-inch thick chart, is to find a board-certified geriatrician, as they have special training in the way medications act in aging bodies. I tried and failed to find someone, so I settled for a caring and competent primary care nurse practitioner who specializes in internal medicine, backed by a hospital-based team to direct and coordinate my medical care. I now seek medical care not for my diseases and disorders per se, but for the symptoms that have been most bothering me at any given point. A pain specialist for ME, physical therapists for tendon and muscular stiffness and loss of balance, and more importantly, a compassionate PCP to coordinate it all. At the beginning of this talk, the picture on the first slide is of a medical practitioner, probably a woman, holding the patient's hand. That's not what I look for. I look for practitioners to whom I can say at the end of appointment, "May I hug you?" And they all say yes. I have accepted that no doctors can make it all go away, and I'm learning to be content with what they, in collaboration with me, can do. Still, in the darkest hours, the little girl in me cries out in the back of my mind for someone then to just fix me. Then, does that sound familiar? That's what we all want, just fix me. But that's what, unfortunately, not all of us can find. Next stop. So what can I reasonably expect? Several generations ago, patients tended to view doctors as all-knowing. Some still do. But that is a very poor basis for a relationship and a very dangerous one, as it can cause the patient to tell the practitioner, yes, that less than is needed, and this can lead to serious medical mistakes, like misdiagnoses. For example, when I was a young adult, I had bad allergies, as I do now, and I told my doctors that I had sinus headaches, so they treated me for that. It was only after I visited a neurologist in my 30s that he said, "How long have you had migraines?" And I said, "What?" He started treating me with that, for that, and cured them. We lay people have finally begun to accept how much less our medical researchers and practitioners know than they don't know about the field of medicine, as the best of them have always told us. All practitioners want to heal us. Let me repeat that. All practitioners want to heal us. That's why they're in the business. When they can't, they feel discouraged. And no one likes to fail. So confronting a patient with a chronic condition forces them to confront the failures of their profession and, by extension, of themselves. Several days ago, I broke my little finger, thinking it was only sprained. I did not seek medical help for several weeks. Then I went to our hand surgeon, the chair of orthopedics, who was a crusty old man who sometimes snarled at me when we met in the course of business, and I told him what he needed to do, which was what he didn't want to hear. Truth to tell, I was slightly afraid of him. But encountering me as a patient, he was incredibly incredibly gentle. And when he told me that he could not fix me anymore, and my little finger is still bent, I saw there were tears leaking down his cheeks. I never again assumed that I knew what a doctor felt about me. We, the patients, need to provide our practitioners with as much data as possible by regularly monitoring our bodies and our psycho-emotional states in the manner of researchers collecting data through observational studies. I don't pretend to monitor myself constantly, but only by fits and starts, when I feel the need for reevaluation of my status. But that serves its purpose of not only providing data to my practitioners, but also of helping me feel more in control of my life. Next. Then, Now on to practical techniques. There's more to scheduling a medical appointment than agreeing on a date and time and then showing up. It is where we start to provide needed information to our practitioner. I once consulted for a large department in my group medical practice, the medicine department, which has lots of subspecialties, and it was consolidating its patient intake operations. We quickly discovered that each subspecialty had its own list of questions to ask prospective patients, some of them lengthy and complex to prepare for each visit. The tasks listed on this slide will help you, the patient, make the most of your visit. First and foremost, tell the scheduler exactly why you want an appointment. Not just this is a follow-up visit, but my medication isn't working, or I'm feeling some new symptom. They will pass that on to your provider, and so your provider will be prepared with that information when they come in and see you. Next, ask for your best time of day. It really is best from a clinical standpoint for us to see our doctors when we're feeling the worst. But if you have a chronic disease, feeling your worst may mean that you can't communicate too well. So in that case, is morning or afternoon better? If you're too ill to travel, you can ask for a telemedicine appointment at most practices. If your practice does not do a telemedicine appointments, consider finding one who does, if that is an issue for you. Be sure to let them know if you need handicap parking, wheelchair assistance, or anything else. And be sure to ask the length of the appointment. If essential, request a longer session. Now, as we all know, our doctors have many patients to see, so I don't advise requesting longer sessions every time. But if you really have a long list of things that have suddenly come up, by all means do that, because your insurance will pay for longer as well as shorter visits. Ask if tests should be done before the appointment. It's very convenient if the doctor has those results when you see him or her. Ask if the provider has access to your other records. For example, I see most of my doctors in Concord Hospital, and they have a patient information system. So my other doctors can see at a glance in the system what my diagnoses are, what medications I'm taking, and so on. And they look at that before they come in and see me in the exam room. And then last of all, for some of us, it's difficult to say, I need help and make an appointment. So celebrate having done with it. Tell your friends and significant others, I made that appointment, I'm finally doing it. Next. Preparing for a new practitioner is even more complicated. When scheduling, be sure you check that the practice accepts your insurance. They will usually initiate doing that, but it's important that you know whether you're going to have to pay for this out of pocket, and you will then need to decide whether it is possible or worthwhile for you. Be sure to prepare your route to ensure that you're on time. The first thing that I went up to Dr. Hitchcock Medical Center, which is roughly an hour north of Concord, where I live. I believed Google and timed it for an hour. Well, I got lost, and it took me an hour and a half, which included the spare time that I always work into any trips. So luckily, I was on time at that appointment. Check if the practice can access your relevant records. Again, if the doctor's in the same practice, he or she may be able to do so. If not, bring a list of current providers, especially your primary care provider. All your medical conditions, including prior surgeries. The doctor needs to know if you're missing any organs, allergies, sensitivities, possibly relevant family records, current medications, past medications that did or didn't work for you, and recent lab results and studies. If you're lucky, the practice will have an internal confidential communication system so that you can message your practitioners. And sometimes when I'm scheduling appointments, I will message ahead, directing it to my doctor, but one of the nurses picks it up and passes it on to the doctor. So that can give them as much information as possible about anything that they want to start thinking about even before they see me. If they have a system like that, I suggest you subscribe to it and learn to use it. It is, as I said, confidential, and its purpose, again, is to help improve the quality of your care. Next. Then be aware of your own emotional predispositions. Medical buildings are stress-inducing environments. Now, stress is a reaction that our ancestors back in the days when they were amphibians developed. And when something scares us, we immediately, our heart speeds up to get blood to our muscles. Our blood pressure goes up to keep that blood flowing. And what does not happen, or what else happens, is that our body, now that we have a rear brain, hind brain, which is the antique part of our brain, and a forebrain, our body focuses its resources on our hind brain, not our forebrain. So we forget things, and we can't think as clearly. This happens to everybody. We may or may not notice it, but it happens. And walking into a medical building can really trigger that. Also, have you had previous trauma, physical, mental, emotional, that was surrounding medical care? I fell down a cliff when I was 7 years old and was in a hospital for a month. Just that experience changed my life, let alone the damage to my brain. Fear of contamination, needles, CT scanners. I am terrified of CT scanners. I have claustrophobia. I'm afraid in enclosed spaces. And the first time I went to get a CT, I was by myself. And when they started wheeling the bed I was lying on into this machine, I panicked. And I sat up and I said, I can't do this. And I left. And the next time I came back, I brought my husband, and he held my hand. And I knew that if anything bad happened, he could rescue me. Fear of possible bad news. It's an avoidance reaction, and we all have it to one degree or another. For some people, it may be a major issue. There are real risks, and we need to calmly evaluate them. And we might have phobias. As I said, I have claustrophobia, and that produces hyperemotionality. There are now, as there weren't when I was young, but there are now therapies for that, which are 80 to 90% effective in dramatically reducing people's anxieties. Most important of all, keep your eye on the prize. This is all about getting better health. So avoiding medical care is not a good idea. Next. Plan for success. As I just said, but in the classic words, stress makes you stupid and forgetful. So write down what you want to say and ask. Begin with a short elevator speech. First, what you most need to discuss today. Second, relevant updates on your condition, symptoms and their context, meaning when did they start? How bad is it? What makes it better? What makes it worse? And then telling this doctor about your medical visits to other specialists. Pack yourself some stuff, your lists. I always take a sweater because I find clinical settings inevitably chilly. And when I get chilly, I get fearful. So I get more and more anxious. Take a book or a magazine. They will very likely will have them, but having your own is better. And if you like them, take a fidget toy or even snacks. And consider bringing a friend to provide support and to take notes. Next. List it, log it, practice saying it. First, what brought me in today, as I said. Second, new symptoms. Rate their impact on your life. Recent diagnoses, changes in medication, if any, including herbs and over-the-counter medicines. Other relevant factors like exercise, social and family history. When I come back from a camping trip, I always feel better. And so if I'm going in to see my doctor and I say, I don't have any pain, I say, and by the way, I was just on a beach in Florida for a week and then in the mountains of northern Georgia for another week. So there's a context. Normally, I feel pain. Any questions you have, be sure to list those. And have available information or logs about your medical history or diagnoses, the major procedures you've had, screenings, and vaccinations. And I'll show you some examples of logs that I keep. Next. Now I realize I'm very obsessive compulsive of this, and also by choice, I used to be an administrator, so I'm used to details. But I keep a health and activity log sometimes. This is the one that's periodic. And I know you can't read it, so I'll just tell you the major things. A date, general notes. For instance, here it says depressed, high in eyebrow twitch. That means I'm anxious. And then sometimes I keep track of my sleep. Sleep from last night, how many hours, what time to bed and wake up, number of nap hours, the total of 24 hours. And then my major illnesses, how much is it affecting me on a 1 to 5 scale? Depression, ME pain, dizziness, stress. And my food, have I been eating a normal diet? And my activities, have I been active or not? This can be extremely helpful to your doctor. And they're not going to want to sit down and read it, or I take that back. They probably will want to sit down and read it, but they don't have time. But you can summarize it, and having written it down, you can look at it in an objective way and say, oh, here are the trends. I have a medication list, which in fact, I keep a copy of in my purse. And it lists my prescription medications, starting with the diagnostic condition, what they're for, what the drug is, its dosage, how often I take it, how long I've been taking it, and who prescribed it. And I give that to every new provider. And I mark on the copy in my purse, I mark in yellow when anything changes or when I add anything, so that I can be sure to tell all of my doctors who don't work in my primary medical practice about those changes. I also list my known drug sensitivities, the antibiotics, and when I reacted badly to them, bronchodilators. You can't expect a doctor to go through your whole chart to find out what's wrong with you, and it may not be in there. You have to be the person who doubles checks to make sure that everything that they need to know is available to them. Next. This one I know you really can't read, but it's diagnosis, treatments, screenings, and vaccinations. I have always had a poor memory for details. And so I have always written things down, and that made it easier when I started to get sick. I have, the first column is the system or diagnosis, in this case, CFS fibromyalgia. And then a date and what was going on. And every time something changes, I add that to it. And I have all my diagnoses on this list, and all the surgeries and treatments and the screenings. The latest stuff I usually highlight in red. And then at the end is a list of screenings I've had, things like mammogram or and a physical breast lump screening, um, and my immunizations. Flu and COVID are the two that I have every year. But I have the record here that I have gone through my shingles, set of shingles immunizations, even polio when I once went back home to India, and the other immunizations that are recommended for people my age. Otherwise, I would forget them. Now, maybe you'll think you'll remember them. And some people do have extraordinary memories and they remember everything. And you are blessed if you are one of those people. But otherwise, write it down. And it doesn't have to be in an Excel spreadsheet. It can be on pencil and paper. You might even want to use a notebook so it's all in one place. Or put it in a Word document if you find it easier to type than to write, like I do. One of my permanent and progressive conditions is a tremor. It's called essential tremor. So I find it hard to handwrite. There are apps for your smartphone you can get. Lots of different ways that you can do this. Now, let me tell you why you should do this. Recent research has shown that when patients visit their physicians armed with lists of symptoms and questions, both patient and doctor find that they lower the communication barriers and they both achieve more satisfaction from the encounters. These lists save time during the visit, increase the doctor's understanding of the patient's problems, increase the patient's sense of control and self-confidence, reduce anxiety, help the patient engage more in the decision-making process. And we know from research that the patients ask more questions when they brought them in writing. These research results are so compelling that many medical practices now are developing surveys for all patients to complete prior to their visits. You may have encountered some of them. But even if your medical practice does it, I'd strongly recommend that you do your own. Next. How your practitioner will have prepared. Yes, they will have prepared. They will have skimmed the latest records in your chart. Charts are designed to have the critical information on the first page. So that any practitioner who opens it can see, your diagnoses, your latest lab tests, and things like that. If they're told by the scheduler, or if you message them ahead of time why you are there for that appointment, they will have considered changes to their care plan. Present your prepared story. Tell the truth. No matter how embarrassing it might be to you, believe me, they've heard it and worse. I said I went through medical school with my husband and our friends, and I mean it. You would not believe what medical students talk about. And of course, a lot of it is the wildest, craziest things that they have heard from patients. So they've heard it all. Don't be embarrassed. You need to tell them what's going on and ask for what you need. And keep in mind, practitioners have down days too. So show them the compassion that you want to receive. Next. Ask, and if necessary, ask again. You should not leave the room until you understand your practitioner's analysis of what is going on. His and her diagnosis, perhaps tentative or maybe to be ruled out. He or she may not have the tools yet to know what your diagnosis is, and that may take time. Her prognosis, what is likely to happen, at least in the short term. Your choices, at least for the next step in your care. He or she may not know yet what your entire care plan is going to look like. And in addition to what your choices are, her recommendation. The phrase I use with my doctors is to say, if I were your daughter or sister, what would you tell me to do? And that makes them realize that I'm dealing with them as a human being to a human being. I'm not going to take them to court on the basis of what if what they told me didn't happen exactly that way. I want their compassionate answer. What do you recommend? Because there's something called clinical acumen. And clinical acumen is the knowledge and understanding that healthcare providers develop during the practice of medicine. They can't always articulate what that clinical acumen is or exactly what it means. But when you ask them for their recommendation, they will be operating not just on the basis of the objective data, but also on what their gut tells them. And that's what you want. And lastly, what to do next? Get blood at the lab, make an appointment for a special study, pick up your new medication, set up a sleep schedule, whatever. If the communication is too hurried or incomplete, express your feelings and needs. If you want to tell somebody that something is not going right, the best way is to say, at the end of this conversation, I feel unsatisfied, or I feel confused, or it doesn't seem as if we are seeing eye to eye. It's really important to me that you understand my concerns. Or I'm worried about my condition and I need to know as much as you can tell me. Or I understand that you have other patients to see, but I'm not comfortable with the level of understanding that I have. How do you suggest that we resolve this without my having to wait weeks for another appointment? None of those are accusatory. And the last thing you want to do is to take your own side in this relationship in such a strong way that you're saying to the other person, in effect, you are the problem. Remember, the idea is to collaborate and work together. So you need to stick up for yourself, and you need to push back when it's called for, but make it in an objective way. And as I said, focusing on your feelings rather than what you think automatically generates empathy and sympathy. Next. How do I feel afterwards? This is your after action report. It helps you analyze what happened and so to prepare for the next encounter. Does it seem that the practitioner cares for me? Now, I'm a behavioral scientist. I can tell you that all we know is other people's behavior. We don't know what goes on in their minds. We don't know what goes on in their feelings. In that example I told you about the orthopedist, I honestly didn't know how much he cared for me. And so I asked, does it seem that the practitioner cares about me? It should seem that way, and you should feel that way. But if you don't, maybe there's something that you can do about your communication with that practitioner to help generate their empathy and sympathy. Did we accomplish anything? Are we moving forward? There's some doctor visits that I've had where, no, we didn't move forward. We just both had more questions to ask. And we walked out of it both with more questions than we had answers for. Do I trust her? As I said, I am a student of trust. And trust is one of the most precious things in the world. But what does your gut tell you? If you feel that this practitioner, if you don't feel that you don't trust this practitioner, ask yourself why and think carefully about it. first, I suggest that you give the relationship a few weeks to develop if it's a new relationship. And then you should consider moving on if you still don't trust that person. And this last thing I'm going to say, which is in this section, which is the most difficult thing of all, is let the practitioner and the practice manager know why you're leaving. The practice manager is the doctor or trained, as I am with a master's degree in the field, in medical care. And they need to know if you feel that this doctor wasn't taking enough time for you or that this doctor wasn't listening. Consider it a service to the future patients of the practice, if you can manage to do that. But the ultimate question for you is, of course, do I want to see her again? Next. Now, are there any questions? And I call this a walk in the forest because I can almost guarantee you that there are some questions we can see now, but as we climb those steps and we get further into the forest, we're going to find many, many more. So I do advise you to make sure that you are connected with people who can help answer those questions. I attend the adult group, I'm sorry, I don't remember its name, but the group that Mass ME has. And it's a great place to learn about this. So, questions?
Thank you, Ruth. I just wanted to step in before we start the questions to give our thanks. It was a wonderful presentation. We're gonna start streaming them from the chat, excuse me, but I wanted to start with one to kick us off. I know you basically put together that high-level overview of all the preparation that you can do before entering a visit, things like your medications, your immunizations, your problems, and the timelines around them. What would your, bare minimum be? Let's say you already know you're going to have a communication issue with the doctor, or you can only get that 15-minute, intro appointment or something. What would be your best advice for the, most prominent thing that you should bring to that visit?
You should walk into the room, and after you greet each other pleasantly, you say, I have 3 things that I need to say. 1, here's why I'm here today, and I need some advice on what to do, suggestion, whatever, however you want to word it. Number 1. Number 2, here are some things that have changed since our last visit. And number 3, I have a list of questions with me. And I'd like to ask you those questions as we go through this or at the end of the visit. If you number things, when you say, I have 3 questions, now here's the first question, the person listening to knows there's another question there, and there's a third question before it's that person's turn to speak. And then after you get through your 3 questions, or however many it is, but I can tell you that most people won't remember more than 3, then that person knows it's their chance to speak. And then it becomes a discussion. Does that make sense to you?
Yes, very much. I really appreciated the perspective you gave of, these physicians are wanting to help people, and often they've got some wiggle room if they can make a longer appointment, in that scheduling first step, you can bring, I need a longer appointment, or I have X number of issues to address. But I know sometimes there's instances where people know they're not getting at that, that's the ideal, and maybe they're not there yet. So I think that would be something people can use as a, minimum list of how can I go in the strongest.
Yeah. Well, now, I am Medicare age, so Medicare pays for an extended visit once a year, no questions asked. That's your wellness visit. And so sometimes if I call up my PCP for an appointment, she will say, I noticed that your wellness visit is 3 weeks from today. Can any of this wait till then?
I see.
Because right now, we would rather just schedule you to deal with the cough that you're having right now, and then she can address these later. So be willing to negotiate.
That's insightful advice, and I'm sure that applies to a lot of other people who are watching this today. Um, One of the other questions we have in the chat from Christina asks what we can do about errors in our medical charts. She says that sometimes it feels that they don't want to correct them, or that they correct them, but they're still not perfect, or it's inadequately done. Um, that she's saying that she would like her records to generally agree with each other, especially for disability purposes. So, like cohesiveness. Is that something like the scheduling? We can do a direct ask. What's the best way?
That's a really good question, and I'm not sure I can give you an adequate answer, but I'll take a stab at it. Um, Put it in writing. Okay. I I I can see my charts at both Dartmouth Hitchcock Clinic and at Concord Hospital Clinic, but I can't change anything in them. But I can send both of them a message that says you only have amoxicillin as one of the antibiotics I'm allergic to, but I also recently took medication Y and I reacted badly to that too. Put it in writing. That is the first thing. Um, if there are things from way back in time in your chart that may make you questionable during the process of determining disability, I would talk specifically with your doctor in an appointment about it and say, I am about to apply for disability, and of course I'm going to need your support. It's
Mhm.
what the doctors say that counts the most for disability applications. And I said, what I'm feeling now and have been feeling for the last year and a half is not what I was feeling before that. So I hope that you focus in your write up on what's going on with me right now. Sometimes they don't list all the doctors that I've seen. That's not necessarily a problem. The critical one is your PCP, because every specialist who sees you should be sending a written message to your PCP saying, here's what I found. And that's why your PCP is the coordinator and even the director of your care, because that is the person who is trained, experienced, and emotionally oriented toward being the compassionate caregiver and taking care of you and collecting all this information and even helping you make sense of it if necessary. So the PCP is crucial. And I noticed in the questionnaire that several people said you don't have PCs.
Mhm.
I have to say that from my perspective, it's the most important thing that you could ever do for yourself when you're a person who gets sick, or even if you're a person who's well, is to have a PCP. You choose them from generally internal medicine. They can be nurse practitioners. For the last 30 or 40 years, I've had nurse practitioners, not doctors, as my PCPs. And they're great. And they have this sort of level of empathy that not all doctors have, even the very best of the doctors. And so they are wonderful for that role. And they really appreciate it. When I come in and say to them, by the way, did you get a letter from Dr. So and so? Because I saw him and, wanted you to know what he said. So I even asked new doctors that I see, you know, here's my PCP. Please be sure to send her a report.
I think that distinction might be new for a lot of people watching this. And at times I used to not know that either. So I think that might be a helpful first step, especially for some of those corrections, reaching out to that ringleader person on your team. I want to acknowledge, I know we're just at 5 o'clock, but we are going to be able to take a few more questions. So if anyone has to go, this will be recorded. Or go ahead, Ruth.
Can I say one thing?
Of
I
course.
did not go to the last slide, and we don't have to go back to it because you're not going to be able to absorb it, but I hope that this can be sent out to people.
Ah, definitely.
You can do your own research. And the way to do it is online to find valid and medical information using most browsers. First, search for phases, putting question marks around the phrase, like chronic fatigue or ME treatment, and it'll take you only to that and directly to that. And secondly, even more importantly, limit the findings to valid sources. So you put, quote, chronic fatigue plus, right after that quote at the end of chronic fatigue, parentheses, edu, comma, org, comma, gov, end quote. And any of you who are internet savvy will know instantly what that means. It means that it's only going to list things from medical schools, nonprofit, and government sites. So you're going to get what the medical schools have to say, including the Mayo Clinic, what nonprofit organizations like the American Cancer Society say, what government sites like the CDC say, and you will not get the commercial sites that are trying ultimately to sell you something. I strongly recommend that. So that's it. Now on to the questions.
Thank you for bringing that up again, Ruth. So one of the questions I want to circle back to, this may be again another solution of putting it in writing or making a really forward request. Linnea had written, how do you handle the matter if you're going to a new doctor's office and maybe they tell you one thing that it's like a scent-free environment, for example, and that's actually not the case, and now you have to walk out because of obvious odors and things like that. I guess something on paper versus the result at the practice? Are those things that people can request, or like you're saying, make it known why you're leaving, perhaps, if it's not going to be an amenable change?
I would add that to the list. This is one of the things I forgot. I would add that to the list of when you're scheduling appointments. Say, I am particularly sensitive to odors. So can you arrange it that I can be in spaces where there are not going to be odors? I have a hard time being, for example, in a waiting room where women may be wearing heavy perfume. Now, the clinicians know better than to wear heavy perfume. But ask that when you're being scheduled. And then, if you still are encountering problems, ask to see the practice manager at the end of your appointment.
Mhm.
I've been a practice manager. I can tell you, I wanted to hear that stuff from patients. Absolutely.
Sure, I guess it's one of those things if you're maybe the message is not getting to the top either if you're dealing with only a single schedule or something to that effect, or the interaction happens and then if you don't readdress it, they don't maybe have a record or any indication that it really happened that way.
Exactly. Now, they can't do anything about what the patients wear. You may be just walking down a hall to an exam room and you pass a patient who's wearing a heavy perfume. The practice can't help that, but they can maybe find you a special place to wait
Mhm.
or a place where there's more air circulation or and things like that. So tell them it's a problem for you and ask for their help. The people at the front desks in healthcare facilities are by and large very compassionate, caring people. They're there because they want you to get better too, just as the clinicians are. And and if they don't, believe me, they get fired pretty fast. And I fired more than a few people in my life because they couldn't quite adjust to the fact that the patient always has to come first.
Mhm. Um,
Heather,
yeah, one of our other questions, Marie is asking, let's say you have an instance where you're in that visit and you've got all your preparation, but you can tell that the doctor is obviously maybe behind, they're late on schedule, they're coming in frazzled. Is there maybe any empathetic wording or something to say to really kind of address the elephant in the room if you're not getting their best self?
point it out. Say, I don't feel like you're hearing me. Again, feelings,
Mhm.
not you're not listening. I mean, never say you're not listening to somebody. They'll go and they'll wake up, but they won't be happy. But say, I feel as if you're not hearing me. And that also involves yourself in it. So it says, maybe it's partly my fault. And I'm not suggesting you say that, but that's inherent in that question. Um, when I've done that, the doctor has always responded by saying, "Oh, I'm so sorry. I had a patient just before you who's been my patient for 40 years, and today I had to tell her that she's not going to be alive by Christmas." And then I go, "Oh, okay." But then, having said that, they will turn their attention to me.
Sure.
Or even if they just say it in their mind, it will enable them to turn their attention to you.
I think we can take one last question here from our audience. Multiple people have asked, what do you do in the instance where there's no primary care providers in your area or there's a huge wait? I know that's really common in many geographical regions right now, just utter, shortage of providers. Um, what's the best way to handle that if you're on one of these incredibly long wait lists?
I don't have an easy answer for that. Um, what I would do is find friends who can drive me and go further. Now, our my church, for example, a church is an unending source of support. Whether or not you believe the stuff in the service, I don't even go to the services anymore. But I can always call on them for a volunteer to help me. And my husband, in fact, does a lot of that. He has a woman he drives every 2 weeks to Boston for, which is an hour and a half each way for her medical treatment, and he waits there while she gets it. Um, Ask for help. And I don't know about you, but for me, that's the most difficult thing in the world. I have an easy time asking my husband for help, and I know that his reaction will be positive, so I don't have any anxieties about it. But other people, it's harder. But you can figure out how you can deal with that situation as it is. We can't, unfortunately, we can't get the right balance of primary care docs and specialists in our society. And the reason is complicated. The main thing is that doctors want to do what they want to do. And if what fascinates them is the gut, God forbid, that's what they want to practice. Um, but if they and we can't force anybody to go into primary practice. Now we do have programs which are very helpful in rural areas and particularly Native American reservations, where the government helps pay for the medical school costs. And in return, the doctor goes for 2 years to a reservation or to a
Mhm.
rural area where people are desperately needed. I mean, there are some villages that have no doctors at all. So, if your kid falls out of the tree and injures an ankle, there's nobody who knows how to bind it up properly. So there are always people worse off than we are, even in this country. But we can't force people to go into primary practice, and the incentives are not there in our pay system. Primary practice docs spend hours and hours and hours reading our charts, reading our lab results, looking through things. I knew one doctor who was seeing a new patient, and this patient had a blood pressure problem. He was an executive with Mobil Oil Company. And and Gary spent an hour and a half going through his chart and making a single chart of his blood pressure at different times. And the patient looked at it and said, "I never thought about this." And Gary said, "Okay, what were you doing here?" "Well, I was on vacation." "Okay, your blood pressure was lower. What were you doing here?" "Well, we were preparing for the visit of a venture funder who might give us a lot more money." And okay, that shows. And that's why I recommend that patients do that themselves. You know, Keep track of how you're feeling and how you're doing. Um, those are things you can do, but you can find the person among your specialists who is the most empathetic and the most compassionate. And think of that person as your primary care physician. He or she will deny knowing enough to do that,
Sure.
but you can say, do you mind if I have my other doc send you their reports? Because I feel I'm able to communicate better with you than with many others. And I need to have somebody who I feel is on my side, and that's you. They will be complimented and they will, on all likelihood, say yes. Unless they're a super specialist in a medical school and they've got to also keep time for their research.
Well, I just got, I worked so hard to get together that list of places. I wasn't so happy to hear that you think a lot of them aren't appropriate. Is that right?
Um, I think that is really insightful advice that people will be able to utilize, even if they're on that 6 or even, unfortunately 12-month wait list. Um, Having someone, even in that interim limbo, who can say, I'm willing to coordinate or take those letters, to be that role for now. But I know, like you said, people having transportation, trying to extend that radius is sometimes the only thing you can do.
Yeah. And another thing is just knowing that people have long waiting lists. One of my neurologists, I have 3 different neurologists at the medical school because I have 3 different diseases and they specialize. And one of them said to me, when we're going to be moving this spring to be nearer to one of my husband's daughters. And one of them said to me, the moment you know what town you're going to live in, find somebody in my specialty and make an appointment with them because it can take 6 or 8 months to see them.
Hmm.
So plan ahead as much as you can. But no, there's no real answer to we need more primary care docs, except that the society is addressing that by developing more physician assistants, more nurse practitioners, and we are very, very slowly moving toward filling that need.
Yeah, I know it's more of a
So
systemic,
hope for the future.
multifocal issue. Awesome. Well, I think that's all that we have time for today. Ruth, thank you so much for your presentation and for answering these questions.
My pleasure.
I want to remind everyone that the recording of the session will be posted on the Mass ME YouTube channel as soon as we can, and you'll get an email when that recording is up. Please feel free to share the video with friends, family, and on social media if you'd like. In addition, we have a few announcements that we are running a series of surveys on healthcare experience, needs, and other topics like access. If you haven't filled it out already, we would really greatly appreciate it. This first one that we sent out can be found in the November newsletter. And finally, we want to announce that our next Sunday Conversation event is going to be in the new year of 2025. We have a little infographic here, but we wanted to debut a new schedule with events that will be occurring every other month and alternating between a community conversations and guest speaker formats. We do ask that if any of you have requests or specific topic suggestions, that you can email them to this events at mecfs.org. We'll be monitoring that email just to inform any future speakers and community conversation topics that we might host. Finally, if you have found this program worthwhile, there are a few ways you can help. You can make a donation to help support the series in particular by donating online at this website, mecfs.org/donate. And there on that same page, you can also sign up for the Mass ME newsletter. And if you donate $25 or more and check that option for Become a New Member, that will establish your membership or renew it, and you'll be invited to our members only programs. So we want to thank you all for coming, and we hope to see you again in the new year of 2025. And thank you again, Ruth, for your wonderful presentation. Thanks, everyone.